Hello, my name is Khuloud AMSHA and I'm presenting our paper on behalf of my co-authors Claus, Bossen, Erik, and Myriam Lewkowicz. In our paper entitled Computer-Supported Knotworking, we propose design guidelines based on comparing two cases in the domain of healthcare. Currently, many countries push for providing more home care. This trend leads to more ad hoc cooperative arrangement to support the continuity of care. The story of Pam can show us what this improvised collaboration looks like concretely. Pam lives with her husband Paul, suffering from dementia. One day, Pam broke her arm. She has to be treated within a short time to avoid worsening the situation of Paul. In this case, home care staff, the general practitioner, the X-ray facility, and the orthopedic surgeon should organize an effective treatment trajectory. Though these actors didn't know each other before, they managed to work together and Pam got back home safely. This is an example of an episode of Knotworking. The concept of Knotworking was introduced by Angstrom and his colleague in 1999. This concept described a cross-boundary way of organizing collective work where the locus of control is either absent or always shifting. In networking, collaboration occurs in episode, depending on the requirement of a particular current situation. Thus, people involved in the networking process create and take part in an improvised collaboration group called knots, which include loosely connected actors. A knot does not fit the traditional definition of a team, which is typically understood to be a stable configuration, nor it resembles the kind of pre-existing network that worker might exploit. Many researchers addressing the complexity of integrated care find the concept of knotworking useful to describe their cases. However, little has been done to support the networking with technologies. Presently, we are facing a transformation of work practice in healthcare toward multidisciplinary, ad hoc, and fragmented collaboration. So if we focus on the research addressing the computer support for these type of work practices in healthcare, especially in non-clinical setting, we can see that these researchers identify some requirements like the need to support care actors for scheduling visits, disseminating and retrieving information, coordinating treatment, and creating care plan. What's common across these studies is the fact that existing shared home care record, whether paper-based or electronic, support only partially this identified need. Thus, several principles have been identified to improve home care record. So, systems supporting collaboration in this setting should allow activity awareness, fluid collaboration, support for collective decision-making process among professionals, considering different sources of data automatically collected through sensors or collected by professionals and by patient and family members. So we aim to contribute to this research area by looking at two concrete cases where health actors face similar challenges. So, in the first case conducted in Denmark, the focus was on supporting a care facility. The care facility is situated between the hospital and the private homes where patients stay a few weeks to recover from, for example, a long stay at the hospital. So, depending on the patient situation, the care staff have to coordinate with multiple actors like hospital, general practitioners, the municipality, taxi companies, pharmacies, and family members. The study lasted for 5 months and was conducted as a combined ethnographic study and a set of co-design activities. In the second case conducted in France, the study focused on the Home Care Alliance Association, which is an association that includes a wide range of health professionals and care professionals that might include nurses, physiotherapists, pharmacists, and professional caregivers. So depending on the patient situation, the care actor change, and in some cases, family caregiver and the patient are active member of the care plan. The study lasted here 3 years, and we used ethnographic methods. We conducted 2 design workshops, and we conducted a pilot study that lasted for 5 months. In terms of solution, the care facility project developed a timeline-based design accessible via a large touch screen. Each patient starts with an empty timeline in the middle of the large screen. Then the staff can put different activities on the timeline. So the overall control of the timeline, event, and collaboration is in the hand of the care facility. The care facility can invite other actors to collaborate. In case of Home Care Alliance, the design solution was an application accessible via tablet. To access the application, care actors can either create a profile or indicate simply their name and profession. The tablet stays with the patient, and the information cannot be accessed remotely. The application offers a place to exchange messages with care actors, allow identifying care actors working around the patient, and keep a record of the patient important information. So in both cases, collaboration is ad hoc, temporary, and shifting with regard to collaboration, aims, and process. In both cases, we find that collaboration can be conceptualized as Knotworking. What characterizes Knotworking is really the high reactivity and reconfiguration of work arrangement. Looking closer at these 2 cases, we realize that we are looking at a special kind of Knotworking. We can say that we are looking at a complex Knotworking that involves a dynamic number of collaborators, a multiplicity of different knots with episodic instance of predictable and unpredictable Knotworking, and constant negotiation of how to cooperate and communicate to solve the challenge at hand. So we argue that these characteristics of complex Knotworking must be considered when designing supporting information technology. By comparing the 2 proposed design solutions, we outline design guidelines for complex Knotworking. Design system should allow to define a flexible access to information, provide an open format accessible and understandable to most people, adopt an open design to accommodate the evolving and diverse actors, enable synchronous and asynchronous information sharing, provide awareness of other collaborators, and finally allow trust building and legitimacy. In summary, in this work, we applied the concept of Knotworking in 2 different cases and conducted a comparative analysis. Comparing the 2 cases allowed us to understand better the Knotworking and especially complex Knotworking situation in healthcare. This understanding has led us to propose 6 guidelines for designing computer-supported Knotworking. Thank you for your interest in our work, and we will be pleased to answer your questions and remarks through the CSCW conference.